I just need all of you to understand that today's webinar is on hip surveillance and cerebral palsy. We have two stalwarts out here. The speaker is Dr. Alaric, and it will be moderated by Dr. Rujata. Also, as I open this, as we start the proceedings, Dr. Rujata Mehta, who's also from Mumbai, she's a consultant pediatric orthopedic surgeon, a hand surgeon at Nanavati Super Speciality. She's also visits Jaslok and Sushrusha hospitals. She's the head of department at the Department of Orthopedics, Wadia Children's Hospital. She's vice president, Bombay, former vice president of the Orthopedic Society chairperson, and empowerment founder secretary. We welcome you, Rujata, to take over this session.
Thank you very much, Asha. At the outset, I'd like to thank Dr. Mallikarjun for allowing me to really contribute to this wonderful initiative on spreading awareness about the hip disease and cerebral palsy. And without much ado, let's move to the next slide. And can I introduce our illustrious speaker today? He's none other than Dr. Alaric Aroojis, a consultant pediatric orthopedic surgeon at the Lilavati Hospital, Hinduja, and at the Baijar Baiwadia Hospital for Children. He's been dedicated in the service to the pediatric orthopedics since many years, almost 23 to 24 years now. And he's also been the vice president of Pediatric Orthopedic Society of India and the chair, CCOT Orthopedics Rehabilitation and Subspecialty Committee. He has numerous publications and book chapters to his credit in national and international books and journals, and received many national and international awards. Besides this, he's also a very, very astute clinician, and you will see how he will guide us through which is the best way to have hip surveillance.
Thank you, Rujata. I'm stopping sharing. Alaric, the floor is all yours.
Thank you so much, Asha. And thank you, Rujata, for that very kind introduction. Many thanks to the executive board of the ISCP, President Dr. Mallikarjun, the Vice President Asha, and the General Secretary Dr. Shakti Das, my close friends. I'm really beholden to the fact that you have invited me to speak today on a very important topic, which is a burning issue in children with cerebral palsy, and that is about hip surveillance. Unfortunately, not many of us are aware of the fact that children with cerebral palsy face a host of various morbidities. And we recognize some of those, and some of them are under the surface. And one of them, which is not very apparent sometimes, is the hip displacement that happens in many of these children. So I'm hoping in the time that I have today, and we'll have some time for question and answers after this, to share with you the importance of understanding why the hips displace in children with CP, to understand how do we screen and diagnose these in time, and having diagnosed them, how to then go ahead with the brief management options that I will present to you. And then we can have some more time for the discussions later. So I'll share my screen. And I'm going to turn off my video to save some bandwidth. I'll also request people who are joining in, and I'm glad to see so many joining in on a Saturday evening, to please mute their audio when they join in. There is still someone whose audio can be heard, so I can request one of the organizers to please mute him. Thank you.
The host can actually put a setting saying mute on entry.
Maria Baiju, please mute your mic. Maria Pandey. Baiju, please mute your mic. Narendra Pandey.
Great, thank you so much. So thank you again for that introduction. What I'm going to be speaking today is about the role of hip surveillance in children with CP, and what better way to do that than to actually begin with a case. So here's an example of a 10-year-old girl who has spastic quadriplegic CP. She is GMFCS level 5 and non-ambulant. These are her risk factors. She was a preterm cesarean section, a history of birth asphyxia. And now the parents bring her at the age of 10 with severe pain in her left hip, which has been going on for the last few years. They did bring it to the notice of their physiotherapist, but that was unfortunately ignored. And now when the pain has become really severe, she is unable to sleep well in the night. She cries incessantly. The limb is in a deformed position, and the parents are finding it really difficult to perform any form of perineal hygiene for her. And if you see her x-rays, this is what is quite obvious now. And as you can see from this, while the right hip is well enlocated, the left hip is completely dislocated out of the socket. And that's resulting in that entire lower limb lying in a position of severe flexion and adduction, preventing them from doing any proper perineal hygiene care. So this is unfortunately a very prevalent problem in children with cerebral palsy. And more shockingly, it's quite preventable if it is screened and diagnosed in time. So this is what happened when we took her up for surgery, because as you can see, she was in so much of pain that when we open the hip up, you can see that the femoral head, which was dislocated, has entirely been denuded of its cartilage. And this hip can therefore not be salvaged. It was excised, and you can see how most of the head has lost its cartilage covering. And that's the reason why this poor girl was so painful and symptomatic. Then, of course, we proceeded after the excision to do a subtrochanteric osteotomy, and post-op her pain has improved markedly. Perineal hygiene is much easier. But she's never going to have a normal functioning hip. And this is the problem that was easily preventable if it were detected in time. So what is the issue of hip displacement in CP? We must understand it's a fairly common condition. If you look at it from the musculoskeletal point of view, it is the second most common musculoskeletal issue after the equine deformity. Almost 1/3 of the children with CP will have a hip displacement. Unfortunately, it's a very silent and progressive condition, but once it becomes manifest, more than 50% of patients will have severe pain and disability. And this is the paradox of this condition, that it is difficult to detect, but quite easy to manage if it is picked up early. But the paradox is that it's easy to detect, but difficult to manage in the late stage. We knew for many years that children who had spastic quadriplegia had the highest risk of a hip displacement, almost in the order of 50 to 80%. We also knew that almost half of the children, even those with other forms of cerebral palsy like dyskinesia or hypotonia, can also have hip displacement. And it's only recently in the last 10 or 15 years that we have understood that it is in fact very much related to the gross motor functioning level. This is an excellent paper that came out from the Royal Children's Hospital in Melbourne, a population-based study which looked at the natural history of hip displacement in CP. And unlike developmental hip dysplasia or congenital hip dislocation, almost all hips in CP are located at birth. But then progressively, for a variety of reasons, they start almost at the rate of 4 to 8% per year. Mentioned earlier, it's very easily missed on a clinical examination, detected on an X-ray, and can be easily monitored on sequential X-rays. You may ask, what is the reason why children with cerebral palsy are prone to hip displacement? And there are several views on this. This was the traditional view, which was called the spastic muscle model, which is fairly simple to understand. Understanding that because of the spasticity of the hip flexors and the adductors, this resulted in a flexion, adduction, internal rotation contracture with scissoring, resulting in increased femoral anteversion and changes in the proximal femoral geometry, resulting in an acetabular erosion with gradual dislocation and femoral head deformation. And this model still holds true, but it's not the only reason why you get hip displacement in CP. More recently, there have been papers which have questioned this traditional view, because we know that this cannot explain why hip displacement occurs in children who do not have spasticity, in children who have pure dyskinesia, dystonia, or even hypotonia. And now 2 important factors have been realized to be the cause for hip displacement in CP, in addition to the spastic hip model. Almost all children with CP we know have negative findings of an inherent muscle weakness, which is very often not obvious because of the spasticity. And this weakness of the hip muscles, especially the hip abductors, results in a progressive displacement of the hip from within the confines of the hip joint. We also know now that delayed weight bearing, which is often seen in children with severe quadriplegia who are non-ambulant, results in a persistence of fetal proximal femoral geometry, which presents with increased femoral anteversion and coxa valga. This results in an imbalance between the octahedral and the hydrostatic stresses across the hip joint, causing progressive acetabular dysplasia and femoral head displacement. In fact, it was a landmark study again from Australia, which I quote, which was published in 2006, a population-based study, which showed a very clear linear relationship between the gross motor function classification system and the risk of hip displacement, showing that while children who are GMFCS levels 1 and 2, who are fairly ambulant, have a low risk of hip displacement, the high-risk groups are the GMFCS 4s and 5s, where the risk of hip displacement is as high as 70 to 90%. This brings us to the concept of the hip at risk. So therefore, we know that children who have spastic quadriplegia, those who are non-ambulant, especially the levels 4 and 5, where there's a reduction of hip abduction less than 30 degrees, these are the children who have a very high risk of hip displacement. However, I must caution you that most of these hips are asymptomatic to begin with, and therefore one must not wait for clinical symptoms to detect these cases, but screen them with X-rays every 6 to 12 monthly, depending upon the severity of involvement. So what are the consequences of hip displacement in CP? That's a question which is quite valid because many of these children have so many other comorbidities. They're struggling with so many other issues regarding the GI tract, regarding swallowing, digestion, regarding epilepsy, and so many other issues. The question really that we have to answer is, how does hip displacement impact a child with CP? We know that if it's a child who's ambulant, a hip which is displaced will lead to a very inefficient gait. But more importantly, the impact is seen in children who are non-ambulant. Once you start getting hip displacement, this results in a fixed pelvic obliquity, resulting in problems with seating and transfers for children with CP. The low side of the pelvis will develop pressure sores because of deformity, and very often you get a bony prominence over the ischial tuberosity and a resulting pressure sore. The restricted hip abduction that occurs because of the hip being progressively displaced will result in a problem with perineal hygiene, and very often they develop severe contractures, and when we start to try to mobilize these children, they occasionally develop femoral fractures. Most importantly, it has been shown that more than 50% of these patients will develop severe pain, resulting in incessant crying and discomfort, especially at night. There's also been some good studies which have shown that if you use the patient-reported outcome measures, there has been a great impact on health-related quality of life index. And if you use the CP child, which is a score that is used to assess the quality of life in children with severe quadriplegia, GMFCS levels 4 and 5, it has been shown very nicely and elegantly that a hip dislocation, especially one which is painful, will have a severe impact on the quality of life of these children and their families. So therefore, why do we then speak of hip displacement in CP? Dr. Shakti Das already explained to us what does hip surveillance actually mean. It means looking for critical indicators which are not very obvious when you look at a child, and to actually try and detect these critical parameters which are responsible for hip dislocation. Hip surveillance is important because we know that hip displacement is common not only in spastic CP, but in all types of cerebral palsy. We know that it's a very insidious and silent problem, and we know clinical examination alone cannot detect early displacement. Finally, we know that early detection allows for early intervention because it will then allow us to undertake preventive strategies. We can then perform reconstructive surgeries to maintain function, and we should definitely reduce or eliminate the need for salvage surgeries. And therefore, hip displacement in CP lends itself well to proper surveillance and a screening program that needs to be developed. It has been also shown very clearly with evidence by the program which has been run in Scandinavian countries for the last 25 years that hip surveillance definitely can reduce the risk of hip dislocation. This is an elegant study which was published to show first the 10-year results And then the 20-year results, which shows that with proper hip surveillance, the incidence of hip dislocation can reduce from almost 9% to virtually nil after a good surveillance program has been initiated. So therefore, you have seen that several hip surveillance programs have been established in certain countries and in certain regions of the world, and they have all shown to be extremely effective. They are becoming the standard of care all across the world. Unfortunately, there are no such guidelines available for India. We looked at a review article which we published in the Indian Journal of Orthopedics last year, which looked at the various hip surveillance programs from around the world. And this is a reference for those who are interested in looking at that article. We compared the various different surveillance programs, and they all had a lot of similarities with very minor differences. But one bottom line that was there and unique to all of these surveillance programs is that the evaluation and screening was not performed by orthopedic surgeons, but was performed by physical therapists. And I know there are several therapists who are attending this meeting today. And this underscores the important role that therapists have in screening children with cerebral palsy. All of the healthcare providers who are the first point of contact between the child, the family, and the orthopedic surgeon. And very often we don't see these children unless they're actually referred to us by an astute physiotherapist or clinician. So here's an example of the hip surveillance guidelines which were published by Australia, one of the most stringent and the most elaborate of all guidelines, which was initially published in 2014 and then revised again in 2021. And then we have also similar guidelines published by British Columbia for the province in Canada, and more recently, the guidelines published by the American Academy of Cerebral Palsy and Developmental Medicine, which attempts to simplify the existing guidelines. Now, how are these guidelines applicable to us in India? We are quite all well aware that there's very poor awareness, not only among physiotherapists, neurologists, and pediatricians who take care of children with CP, but even among orthopedic surgeons. We know that most cases of hip displacement present late, much after the onset of pain, or once these children have severe functional limitations. And this therefore precludes any reconstructive surgery, and then many cases have to go towards the salvage surgery with poorer outcomes, as I've outlined in the very first case that I presented to you. So therefore, we must understand the context. And whenever we are developing guidelines for a specific population, we must understand that guidelines established for people in different healthcare systems may not necessarily be true for us in working in low middle income countries. I don't need to belabor this point of the attendees here are working in this country, but we know that we suffer from overpopulation. We know that we have a very poor public healthcare system where less than 1.5% of our GDP is allocated to healthcare, compared to an average of around 17% in US and a 10% global average. We know that we suffer from a lack of infrastructure and a shortage of doctors, especially in rural areas where more than 2/3 of our population lives. We know that more than 10% of India's child population has developmental delays and disabilities. And the distribution of healthcare is markedly skewed in India, where more than 2/3 of the doctors practice in urban areas where only 1/3 of the population lives. And therefore, there's a large variability in the quality and equity of healthcare services across our country. To understand whether we really need to develop guidelines for our country, we ran a survey of our members of the Pediatric Orthopedic Society of India to look into the fact whether there's any potential support if we were to develop guidelines specific to India, and to identify if there were any knowledge gaps and obstacles to implementation. Out of the few who responded, we noticed that more than 96% agreed that hip displacement requires standardized monitoring. About half of them reported using hip surveillance guidelines. But remember, this is a biased sample because these are experts who are pediatric orthopedic surgeons, and this does not necessarily extrapolate to general orthopedic surgeons in our country, many of whom are quite unaware that the hips can be a problem in children with CP. Very encouragingly, more than 97% indicated that hip guidelines are needed, with 9% expressing interest that if guidelines were developed for India, they would definitely adopt them. What was also highlighted, as we suspected, is that many orthopedic surgeons get late referrals, that they're not referred patients well in time when reconstructive surgeries are effective. and they often
I
have
was,
to
yeah,
see
I was
patients who
using
come to them
AdWords in
pretty
front
late.
of trains right now.
Finally, they also said that their perceived barriers to implementation included the lack of guidelines, as well as poor awareness among surgeons, physiotherapists, pediatricians, and families about the fact that children with cerebral palsy can have hip displacements. So this brings us, therefore, to the fact that we realize that hip displacement in CP is a problem, and we need to find a solution to it, which is specific to our healthcare settings and to the context in India. And hence, during the time of the pandemic, when many of us were not employed or sitting at home because we weren't in the front line taking care of patients with COVID, we decided that this was the opportune time to develop a national hip surveillance guideline project specifically designed for the country. While Posty took the initiative, I must compliment the members of the ICP who were very important partners and stakeholders in developing these guidelines. We received a lot of positive feedback and a lot of help from members of the ICP, which all of you know is a multidisciplinary organization comprising not only of physiotherapists and occupational therapists, but rehab specialists, orthopedic surgeons, neurologists, and several other healthcare professionals who are involved in the care of children with CP. We then liaised with several other national organizations, including the Association of Child Neurologists, the Indian Association of Physical Medicine and Rehab, the National Associations of Occupational Therapy and Physiotherapy, and our parent organizations, the Indian Orthopedic and the Indian Academy of Pediatrics. I must definitely acknowledge the fact that we had a lot of help in the form of technical expertise and funding provided by the BC Children's Hospital in Vancouver, Canada, and a trust called the I'm a Hippie Fund. To understand how to develop a hip surveillance pathway, we understood that we need to follow a certain pathway. And we used 4 pillars to create a screening pathway based on creating awareness among the stakeholders, generating the evidence from literature, developing consensus where evidence was absent, and then finding methods of how to implement this throughout the country. Rather than just sitting together with a group of people, I understood that we should follow a very scientific method which will stand the test of time. And we published this in the Journal of Indian Orthopedics in last year, which showed a very clear developmental pathway of how we went about developing the guidelines. The first stage, as you can see, was the preparation stage where we assembled an expert group of key organizational members and stakeholders, conducted surveys, one of which I showed you already, the survey of the Pediatric Orthopedic Society of India. We then familiarized the group with the existing literature and did a very extensive literature search for almost a period of 4 months. And then to establish consensus was the Delphi approach, which is an iterative process of running various consensus statements across the panel, with the panel voting either in or voting a statement out. And once we had a list of consensus statements, we then had a core writing group which finalized those statements together to construct a pathway which was relevant for India. So here are the phases as I've shown you. This was a 1-year project, each phase lasting for about 4 months. As I've already outlined to you, the first phase was setting up the expert committee, creating awareness and generating the evidence of literature. The second phase was develop a set of consensus statement with the Delphi approach. And finally, the last stage of actually framing those guidelines by a co-writing team. I won't go through each of this in great detail, but as you can see from the Delphi approach, we looked at various important parameters that needed to be a part of the pathway. Who were the population that we were surveilling? Who were the target providers that needed to perform surveillance? What was the role of clinical examination and what are the points on clinical examination that should be included in hip surveillance? What are the type of x-rays that are required? When would you discharge a patient and refer the child to an orthopedic surgeon for further management? And hence we then came out with this pathway. And for those of you interested, you can point your camera to this QR code, and this will give you a link to the various guidelines that we have established. This is available as a free download on the Pediatric Orthopedic Society of India website. It is a free resource available to everyone as long as you acknowledge the fact that this is available from this website. And you may download this, print it out, and put it up in your clinic for easy usage. I won't go into much of the details because many of these guidelines are available on the resource that I pointed out to you. But I would just summarize by saying that we divide the children according to GMFCS levels and depending upon the age. We use clinical examination and a single AP X-ray of the pelvis of both hips to decide when to surveil children depending upon the GMFCS levels. And very broadly speaking, divided children into 3 groups: GMFCS levels 1 and 2 in one group, level 3 in the second group, and 4 and 5 in the third group. And what we recommended from our surveillance is that whereas children with GMFCS levels 1 and 2 need clinical examinations every couple of years, they would require an X-ray only 3 or 4 times in the entire childhood, which is at age 2, 6, and 10 years. Children who are more involved with a level 2, with a level 3, would need a yearly clinical examination and yearly X-rays. Whereas children who have GMFCS 4 and 5 require more frequent clinical examination, especially between 2 and 4, where the risk of hip dislocation is very high, where we then perform clinical examinations and X-rays 6 monthly. And then if we find that those children are at risk for a hip displacement, we call them more frequently. If we find that the migration percentage is more stable, we call them once a year. So in an essence, this is what hip surveillance is all about. We also developed several graphics for knowledge translation, and these are also available for you to stick up in your clinics, showing you how to position a child who has a hip flexion deformity so that you can get a proper X-ray done. We have some nice graphics showing the CS levels, adapting the work done at Royal Children's Hospital in Melbourne and making it more contextual for India, using more Indianized versions of the various pictures showing the GMFCS levels and how to identify a child with a type 4 hemiplegia. So the basis of all examination for hip surveillance is a clinical exam. Though we know that it is not a very sensitive test and you can miss a number of children, this still should form a part of our decision-making matrix. Besides looking at the age and the GMFCS levels, we must look at the topography because we know that children with quadriplegia are the highest risk for hip displacement. Understand that a part of the decision-making matrix also revolves around the presence of comorbidities. Many of these children have got severe GI and respiratory problems, and therefore decision-making must factor this into the process as well. Whenever you do a proper examination, a history taking is crucial to look for presence of pain, functional limitations, problems with sitting balance, and perineal hygiene. Doing a detailed clinical examination of the hip, the spine, looking for the limb line discrepancy and the torsional profile. And then do a generalized preoperative workup involving standardized X-rays and spine X-rays. So as I've shown you, clinical examination includes understanding the motor type and the topography. For children who are able to walk, that is levels 1, 2, and 3, do a proper gait examination. If you don't have the facilities of a gait lab, you can do a simple video examination, as you can see here. Examine things like the tone by using the modified Ashworth, Cardio, and the popliteal angle scales. Use various tests such as the Thomas's test and the hip range of abduction. And finally, don't forget to assess the torsional profile because many of these children will have torsional issues either in the femur or in the tibia. So here are some of the clinical tests that we are performing. The Thomas's test in the top left, then the popliteal angle test, the test for hip abduction, and finally the hip torsional profile test. And then have a very simple proforma that you can use for testing for hip abduction. As you can see here, the number of data points are very few. All you're looking for hip surveillance is to know the age of the patient, whether pain was present on history or an examination, to note down the GMFCS level of the child, and then to perform the hip abduction angle and the migration percentage. For many of you are not familiar with migration percentage, this is the only radiological parameter which we need to assess for a hip displacement in children with CP. There are several other parameters as well, such as the acetabular index and the head shaft index, but for simplicity's sake, we'll use just the migration percentage. This was described by Reimers and was measured on a single AP X-ray of the pelvis with both hips. What you need to draw are a few lines. The first line is the Hilgen-Reimers line or the H line, which passes through the triradiate cartilage, and then a vertical line, which is called the Perkins line, which is drawn on the lateral border of the acetabulum. And what you then have to measure is the amount of the femoral head which is lying outside of the Perkins line, divided by the total width of the femoral epiphysis multiplied by 100. So in this case, you can see that more than 3/4 of the femoral head is lying outside the Perkins line. And therefore, the migration percentage here is A upon B multiplied by 100, which is 75%. You can also nowadays use a smartphone app, and I don't generally push for any specific apps, but we have found this to be very useful in our clinical practice, because rather than taking an X-ray and then tracing it out and taking a pen and a pencil and a goniometer to measure those angles, you can now do this very simply on a smartphone app. And this is a free app available on the Android Play Store and the Apple Store as well, which is called the Hip Screen app. It was designed by Vedant Kulkarni and his team from the US, from California. And as I've said, it's a very useful app because it tells you the various different surveillance guidelines available across the world. It gives you a schedule for hip surveillance, and actually helps you to measure on the app itself the amount of hip displacement using the migration percentage. And I have a small video which shows how that is done. So here you take a photo of the X-ray. You have the potential on the app to rotate the photo around so that you have absolutely standardized horizontal view of the pelvis. And then you go about laying out the grid lines over that X-ray, focus the head of the epiphysis between the black and the white lines, and then read off immediately how much the migration percentage is. Each line here corresponds to 10%. And you can see here that 1/3 of the head, or 30%, is lying outside the Perkins line. And therefore, the migration percentage here is 30%. So this is a very simple app to use. And in a matter of a few seconds, you can diagnose the migration percentage. It does not need that every child with cerebral palsy be referred to an orthopedic surgeon, but you as a physical therapist or occupational therapist or a neurologist or a rehab specialist can download this app, measure the X-ray, and if the child has a migration percentage of more than 30%, refer these children on to your general orthopedic or pediatric orthopedic specialist for further management. So I'll come down to the final part of my talk, which is about the management. And the question is, why treat spastic hip disease? And we have talked about this before. We have said the problems that exist because of hip displacement results in abnormal gait in children are ambulatory. And if you treat them and manage them properly, you can improve the gait in children with CP. You can improve the function, the sitting balance, and the ease of transfer for children who are non-ambulant. You allow for better perineal hygiene and less bursting care, potentially hip contractures and pressure sores, and most importantly, to avoid degenerative arthritis and pain, which happens in more than 50% of these children. So there are two treatment strategies that have been described. One is a proactive approach and the other is a reactive approach. The proactive approach is what is generally recommended, that you don't wait for symptoms to develop. Based on the radiographic screening, before the onset of symptoms, you initiate treatment so that you can manage these children before problems develop. But there is a role for reactive treatment as well. If you have a child who is severely disabled, who has severe comorbidities, so a very poor risk for anesthesia, then you can actually wait for symptoms to develop, though it is a less optimal approach, but it is valid on a practical basis because many of these children may not be good candidates for very extensive reconstructive procedures. But in general, we prefer a proactive or a prophylactic strategy rather than a reactive approach to treating children with hip displacements. The management of hip displacement largely revolves around three fields: preventive, reconstructive, and a salvage option. And I'll go through each of these with you in detail. We must look at treatment in terms of evidence. And we know that a lot of non-operative approaches are popular in the form of physical therapy and stretching, the use of botulinum and abduction bracing, or even certain seating and standing systems. Unfortunately, as far as evidence is concerned, not many of them have been shown to have an effect on hip displacement. I'm not in any way discounting the importance of physical therapy, the role of active stretching, or the role of bracing. But as far as hip displacement is concerned, once hip displacement starts happening in a child with CP, especially once it crosses 30% of migration percentage, that hip will inexorably start displacing more and more, irrespective of any form of conservative treatment. The only evidence which has been shown to work is in the form of orthopedic surgery, either doing soft tissue releases or major bony reconstructive procedures. And what we definitely want to avoid are the salvage options that are presented in the very first case of this talk. So soft tissue releases are the mainstay to prevent a deterioration of hip function. Once you have a child who presents with a hip displacement of more than 30%, that's the time when the orthopedic surgeon can intervene and perform soft tissue releases in the form of an adductor and gracilis release, also lengthening the iliopsoas and doing either a frenulization or a neurectomy of the anterior branch of the obturator nerve. And this has been shown to improve the passive hip abduction. It improves the wheelchair sitting and perineal hygiene, especially in children who have severe scissoring and who have problems in placement of the limbs on a wheelchair or in bed. It's very ideal for younger children. So the best results are seen in children who are less than 6 years of age. And the two important predictors of success are the GMFCS levels and the initial migration percentage. So we know that it works best when the child is young and when the migration percentage is less than 40%. Once the migration percentage exceeds 40% and you have significant changes in the proximal femoral hip geometry in the form of coxa valga and hip anteversion, as can be seen here, soft tissue surgeries by themselves will not correct the process. Because the bony changes that you can see, and both these hips have a hip displacement of more than 50%, you have to perform bony surgery to realign the hips. And what we do is a combination of a femoral osteotomy with or without an acetabular procedure, depending upon the extent of acetabular involvement. So here are a few examples. Here's an 8-year-old boy with a quadriplegic cerebral palsy. You can see that on the right side, the hip is displaced by almost 50%. And this child underwent open reduction of varus osteotomy of the femur. And you can see now it's very well contained, which will last for several years, even on long-term follow-up. Here's another child who has bilateral hip displacement at 8 years of age, GMFCS level 4. You can see that the right hip is displaced by 50%, the left by 60%. And we always do bilateral surgery. You can do them simultaneously or you can stage them. We prefer doing a staged approach because this is a big surgery. Many of these children do not tolerate prolonged anesthesia or blood loss. So we stage them out by around 3 or 6 months of a gap. And you can see that the left hip is very well located within the acetabulum now, and he's awaiting surgery on the right side. What we definitely want to avoid is what I showed you in the very first case, that if you screen these children well in time, if you do X-rays and clinical examination as per the surveillance schedule, you'll be able to pick up children much before they come with actual clinical symptoms of pain and disability, when the only thing left with us in armamentarium is an excision and a salvage procedure, which though while it gives relief of pain and improvement in the sitting balance, it will never have the same outcome as replacing or reconstructing a normal hip. So I'll leave you at the end of this talk with the hip surveillance guidelines. As I pointed out, this is freely available on our POCI website. You're free to download this, put up a picture in your clinic, refer to it as much as possible. Remember that this is a living document. We do not want a hip surveillance program to just be something which is there to listen to and not implement. But the success of this program will depend on the implementation by each and every one of you. And if you go back to your clinics tomorrow or on Monday, and you start looking at every child with cerebral palsy and understand that no child is immune to hip displacement. Even a child with level 2 or level 3 can have a hip displacement. But more importantly, children with GMFCS levels 4 and 5, look at them with a magnifying glass, understand that hip displacement is a problem. It may not be picked up very easily. And it's you as an occupational therapist, physical therapist, neurologist, rehab specialist, orthopedic surgeon, or anyone involved in the care of children with CP, even a parent, to behoove your healthcare specialist to actually assess the child with CP and get frequent clinical examinations and X-rays done as per the screening protocol. More recently, once we came out with the protocol, we actually did a formal release. Many of you attending today were part of this development process. We launched the guidelines at our post-in mid-year meeting in July of this year. But more importantly, as I've explained to you, just having a guidelines on a piece of paper is not going to be useful to any of us unless we actually implement that into our daily practice. So in conclusion, I would say that spastic hip displacement is a silent problem. It is very, very imminently preventable. And all it requires is a keen eye and the knowledge of every health professional who deals with a child with CP, that every child is a candidate for a hip displacement. It will only be picked up with very rapid and regular screening. It's important to diagnose these and treat them aggressively when they're young, when simpler surgeries can help to prevent a bigger problem. Understand the concepts that certain hips are at risk for hip displacement, and try and institute a hip surveillance program in your own institute, in your own clinic, in your province or region, and in the country at large. So thank you very much for your attention. I put up 3 QR codes here. For those of you who are interested, you can point your camera to this. The first one is the guideline development process, which is available on our POSI website. The second one is the actual surveillance guidelines, which you can download and you can put up in your clinic. The third one is the review article, which we published in the Indian Journal of Orthopedics last year, which talks of the importance of hip surveillance and many of the points that are brought up in the talk today. So thank you very much for your attention. I'm extremely grateful to ICP for allowing me to speak on this very important topic, which has been very much ignored over the last many years, but which now hopefully will have many people from India talking about. Remember that this is a concept which came about more than 2 decades ago from Scandinavia. And while they have been able to reduce the burden of hip disability and hip displacement because of very stringent surveillance guidelines, in India, we are still on the starting path. But I believe that everyone has a role to play, and every little drop will help to build up the ocean. And I look forward to a time, maybe many years down the line, when as orthopedic surgeons, we will not see a single child who comes to us with a very advanced hip displacement or dislocation, but which are picked up early by the healthcare professional because they are astute and they are aware of the hip surveillance guidelines, and they refer the patient to the orthopedic surgeon as early as possible for intervention. So thank you very much for your attention.
Thank you, Dr. Alaric. That was indeed a very, very comprehensive overview of everything about hip surveillance and cerebral palsy. I've seen several questions being poured in on the chat box here. Right from saying, tell us what is CP and what does hip surveillance mean? I think it's come down to which is the commonest surgery in CP. So you've already covered the topic in great detail, but maybe you could just summarize saying which are the 3 most important age groups that hip surveillance must have, where we should watch out for them, and what is the commonest surgery you should do in each of these age groups.
Sorry, I'll unmute myself. Yes. So, as far as the diagnosis of CP, I think all of us on this panel are well aware of the diagnosis of CP. And hip surveillance should start as soon as you've made a diagnosis of CP. We normally say that we can make a definitive diagnosis of CP by the age of 2, but there are various other methods nowadays where even children as early as 6 months of age can have an early diagnosis of CP. So as soon as a diagnosis of CP is made by a neurologist, as soon as the child enters into the high-risk clinic, I think it behoves us to do hip surveillance. So while we say that 2 years is the age by which we should start, I really feel that once a child with CP is diagnosed, especially if you have a child who is GMFCS level 4 and 5, and remember the GMFCS levels can be used at all age groups. While we constantly talk of the GMFCS between the age of 6 and 12, there are different parameters that you can use for children who are less than 2 and between the ages of 2 and 6. So using the GMFCS levels and using various methods of early diagnosis of CP, once your diagnosis of CP is made, start looking at the hips at every visit that the child makes to you. Remember that children, as I've said, who are the highest risk for hip displacement are the ones who have spastic quadriplegia, because they have an almost 90% risk of a hip displacement. But even children who are ambulant, even children who are GMFS levels 3 and 4, also have a significant risk of hip displacement. And all that requires is a simple hip examination every 6 monthly and X-rays either 6 monthly or a year. If you don't want to be bothered, by too much of, looking at that chart and seeing when to plan hip surveillance, I think the easiest way to remember is that if you get an X-ray done at least every year for a child who has GMFS level 4 and 5, I don't think you will miss any case of a hip displacement. And once you see a hip displacement out more than 30%,
What is the access now through C, right?
That is the time you should refer the child to an orthopedic surgeon. So we don't want you to refer every child with CP to the general orthopedic surgeon. We know that we don't want to fill up our clinics with children for screening. Screening and surveillance, as you can see, the common thread from all surveillance programs across the world is done by physiotherapists, is done by occupational therapists, is done by rehab specialists, is done by neurologists. And we come into the play only when it comes to managing these children with CP. So thank you.
Yeah, another question is, can you highlight a little more about the hip abductor angle and exactly how to do it in clinical practice? Because that is something which everybody can implement at their own personal level as well. And how would you red flag that?
So hip abduction angle is not a difficult measurement to make at all. All you need to do is have the child lying supine. And if you go to our website, posi.in, you'll find all the graphics that explain to you how to do this very simple clinical test. So once you have the child lying supine, you then have to abduct the hip one at a time. So I avoid abducting both the hips together and measuring what we call the common hip abduction angle, because that does not mean anything. A hip abduction angle, a common hip abduction angle of 60 degrees can mean 10 degrees of abduction on one hip and 50 degrees on the other hip. So people who measure a combined hip abduction angle has not much of value at all. Measure each hip individually. So you draw a line across the long axis of the body, and you see with the pelvis being square, how much the limb can be abducted against the plumb line of the body. And you may use a goniometer or you may just eyeball it. But if you have a child whose hip abduction is less than 30 degrees, that is a very important risk factor for hip dislocation. But I must reiterate the point again, that this happens very late in the course of the disease. If you're waiting for clinical symptoms or restriction of hip abduction to tell you that the hip is a problem, when you take an X-ray, the hip may already be dislocated by more than 50%. And therefore, the importance of screening. Screening means detecting something before it becomes a problem, not after. And therefore, the X-ray is the only way to detect that. So getting a standardized AP X-ray of the pelvis, and again, there are papers which have explained very clearly how that should be done, how to standardize an X-ray, and then how to measure migration percentage very easily. And we use the hip screen app in our own clinic, and we found it to be extremely useful. We have trained our physiotherapists also in our hospital to use the hip screen app. All of them have downloaded it on their phones, and they measure the hip abduction angle and they measure the migration percentage on the X-ray themselves every time the child comes to them for a visit. And only when the migration percentage crosses 30% or the hip abduction falls less than 30 degrees, do they refer the child to the orthopedic surgeon.
One more question which has come on the chat boxes. How do you implement this at the rural level? Again, you're muted.
That's a great question. So we understand that healthcare is so variable in India, and that's exactly what I brought up in the slide, talking of the context. And whether it's an urban setup or whether it's a rural setup, I don't think it matters much for hip surveillance because of the fact that the screening is done with a simple X-ray. It doesn't require an ultrasound. It does not require an MRI. It does not require very fancy tools. Every single primary healthcare center, every single hospital in India has access to a simple X-ray. And all it means is that what the mind does not know, the eye will not see. Once you're aware that children with CP are at risk for hip displacement, the onus is then on you to examine each of those children every time the child comes to your clinic. It may not be every month, but at least every 6 months, while you're examining these children, spend 2 minutes on examining the hip, looking to see whether there's any symptoms of pain, whether there's any restriction of hip abduction, and getting a hip X-ray done for these children. Remember, getting 1 or 2 X-rays done in a year is not a big deal for these children. You don't need to get x-rays more frequently. We know that every x-ray is a radiation risk. We know that these children have multiple other issues. They will need x-rays for other reasons. For example, chest x-rays for chest congestion. They might need GI x-rays required. So limit the number of x-rays required in these children. But 1 or 2 hip x-rays in a child every year using the appropriate gonadal shielding is not a big problem and is not a significant radiation risk. So I don't think whether it's rural or urban India, I think hip surveillance in children with CP is very easily done as long as we are aware of this entity and we have our hands to detect the hip abduction angle, and we have an app on our smartphone to diagnose the migration percentage on the X-ray.
There's a little elaborate question by someone who says, I think there's a difference between surveillance and screening. Surveillance is periodically carried out in high risk.
हमसे बोले कि व्हाट्सएप कर दो, सर कर दीजिए.
Rujata, unmute yourself.
I think there's a difference between surveillance and screening is what the question reads. Surveillance is periodically carried out in high-risk babies. I presume the American Academy of Cerebral Palsy recommends motor surveillance at 6, 12, 18, 30, and 48 months. Can you please comment if non-achievement of any motor development in these months will put the child at risk of developing hip dysfunction? It's a little elaborate question, but I think borders more onto pediatric neurology.
So surveillance and screening are pretty much the same. I think they're more of English words. The word surveillance gives the importance of periodicity. So someone needs to mute their mic, please. Rujata, maybe you need to mute your mic. Thank you. So while screening seems to indicate that it's a single one-time event, surveillance is probably a more appropriate term. Ultimately, they're sometimes used interchangeably. But I understand where this is coming from. Screening sometimes is a one-time process. You do it once and then you forget about it. And that's true for some other conditions around that children suffer from. But surveillance indicates that it should be periodic. It indicates that every time the child comes to you at the different schedules that we have put up, that if you have a child with GMFCS levels 1 and 2, you can examine the hips every second year. If you have a child who comes to GMFCS level 3, examine the hips clinically once a year. If you have a child with GMFCS level 4 and 5, examine them more frequently, that means every 6 months. So what surveillance means is the periodicity of the screening. It's not really important as far as, what are the timing exactly, whether it's at 6, 12, 14, 18 weeks or months. But what is more important is that the frequency should be regular. It should be done at least every 6 monthly, every yearly. If you want to follow a schedule by all means, and that's what we have developed using our guidelines. But I think the main focus of developing surveillance guidelines is to create awareness, to understand that such a problem exists, to understand there's a treatment available, and if you refer the child early, we'll be able to treat the child well enough. So as you can see that there are various similarities and differences between the different screening guidelines published across the world. What we did with the hip surveillance guidelines in India is to make it very contextual, to make it situational, to understand that the healthcare system in India is very different from a socialized healthcare system that you get maybe in parts of Canada, in Australia, in Europe. And there, when you have a registry, it's very easy to track children down, not so in a country like ours. And therefore, what we have done with our process is to simplify the screening or the surveillance guidelines to make them more appropriate for our healthcare settings. But I would say that you can use any surveillance guidelines from across the world. They are all very similar and they only have some minor differences. So whether you'd like to use the Australian guidelines, the AACPDM guidelines, or our newly published Indian guidelines, it's all fine, as long as you understand the importance of why you're using those guidelines.
There's another lovely question from Meet Ashwin Jain. Is there something in the guidelines that we can explain to the parents so that they can contribute to this surveillance as well?
Yes, I think it's very important that we empower parents. I know in several conditions that we treat, it is the parents who have made the first move. One of the other conditions I treat a lot of is clubfoot. And a technique which came out many years ago was not very popular, called the Ponseti method. And it's only when parent support groups started pushing for the Ponseti method, which is the conservative method of managing clubfoot, that over the last 20 years, there's been a paradigm shift in the way we treat children with clubfoot. We no longer do those very extensive surgeries, but we now treat all these children with simple plaster cast treatment. So the point I'm trying to make here is that parents can be one of the strongest advocates for their own children. And empowering the parents to understand the importance of hip surveillance cannot be undermined. And therefore, in part of our phase 3, where we're talking of developing knowledge translation tools and implementation across the country, the parents and parent support groups are going to be forming a very integral part of this committee, because they are the ones who are going to help us to develop translation tools that will be understood by lay people. All I say is, for now, tell your parents that insist that their children are examined for hip problems every time they visit a healthcare professional who deals with their child, whether it is a neurologist, whether it's a physiotherapist, whether it's a rehab specialist, whether it's an orthopedic surgeon. If parents push for this and tell their healthcare professionals that, we are aware of the fact that our child may have a hip displacement. We know that this is not often picked up by healthcare professionals. Please examine my child's hip and get an X-ray done. I think they can be very strong advocates for pushing hip surveillance in this country. So empowering parents as part of this entire process is going to be a very important part of implementation of guidelines across this country.
So that's been lovely so far. I think any other questions from Dr. Mallikarjun or Asha or anyone? The number of people who've raised their hands, is there something that they want to ask, or they can lower their hands now?
Well, I guess whatever questions were there, we had asked them to put it in the chat. Great presentation and great moderation, Rujata and Alaric. Alaric, I just want to say 2 things that you could tell the crowd is the role of hip surveillance in kids with hemiplegia. That would be really good, because there are lots of therapists in this group. And I guess how important it is as a transdisciplinary approach that, as you already mentioned, but it's best that one ortho evaluation is always the best, and when it should be done. I think so. Coming these 2 points, if you bring it out, would be great. Thank you, Alaric.
Yes, thanks, Asha. So children with hemiplegia are a unique group. Children with hemiplegia generally are GMFCS levels 1 and 2. We almost very rarely see a child with hemiplegia who is more extensively involved in that. Though you can get a level 3 child in hemiplegia, most of them are levels 1 and 2. And therefore, as far as the guidelines are concerned, you'll find that there's a hashtag in one of those recommendations which says that children with what we call Winter, Gage, and Hicks type 4 hemiplegia, which is a specific gait pattern, have to have hip surveillance little more than the GMFCS level 2s. So whereas the GMFCS level 2 children, we stop surveillance by 10 years of age because the risk after 10 years of age is very low. Children with hemiplegia, especially the Winters, Gage, and Hicks type 4. Type 4 is very simple. All that they have is an extensive involvement in all 3 planes. They have foot deformity, they have knee issues, and they have hip issues as well. So they have involvement of the entire upper and lower limb. And these are the children who are at risk for hip displacement later on. Unlike the quadriplegics who come with hip displacement in the early stage between the ages of 2 and 6, children with hemiplegia generally present with hip problems after the age of 10. And therefore, in this specific unique age group, we have tweaked the guidelines that even if they're GMFCS level 2, we do not stop hip surveillance at 10 years of age, but we continue the hip surveillance till skeletal maturity and even beyond, because these children are at risk for hip displacement and hip dysplasia after the age of 10 and not at a younger age group. So that's the unique feature of hemiplegia, which is the Winters, Gage, and Hicks type 4. The second part was you asked about the role of, I missed that again. Can you repeat that? I forgot what the second part of the question was.
The second part of our question is that as a therapist, not only early intervention, but I think so, there should be some cutoff where a therapist should not forget, because we are on a transdisciplinary team, that an ortho evaluation is very important.
Yes, I agree completely. But at the same time, if you don't have access to good orthopedic care, my point here of hip surveillance is that do not say that I cannot perform hip surveillance because I don't have an orthopedic surgeon available to refer a child. There are facilities available elsewhere. So I think as a therapist, your role would be to highlight the fact that hip screening is important, to do hip screening yourself, because that's a common thread across all types of hip surveillance across the world. The therapists are the ones who are empowered to screen children with CP for hip problems. And if you have an orthopedic surgeon in the vicinity who knows how to treat this, that's fine. Otherwise, refer those children to a higher center, because treating these children with hip displacement is not very simple. You have to understand that these children require good anesthesia care, need good post-operative care. Some of the surgeries can be done in small setups, but they sometimes don't have the facilities for providing good post-op care or good anesthetic care for children who have sometimes very severe comorbidities. And many complications can happen after the surgery, not related to the surgery per se, but related to complications of chest infections, atelectasis, requiring a ventilator support, requiring GI problems as well. So if you have a child who's highly involved and you find that the hips are a problem, refer the patient to a center where such care is available, because we should not take the care of these children lightly. These children are at risk for complications even afterwards, and therefore you must refer these patients to the appropriate care. But that does not prevent you from doing hip surveillance. That does not prevent you from screening these children on a regular basis to pick up hip displacement, because treatment is available somewhere or the other for these children. If you are part of a team, which Asha has rightly pointed out, and we work in urban areas and in large hospitals, have that luxury that we do have teams around us where we have occupational physiotherapists, rehab specialists, orthotists, neurologists, and orthopedic surgeons all working together. I acknowledge not many centers across our country have that facility. And that's why I want to empower each of you today, whether you are a parent of a child with CP, whether you are an individual who has CP, whether you are a therapist, a neurologist, or a rehab specialist, understand the importance of hip surveillance and get screening done on a regular basis to pick this up before it becomes a problem. Thank you.
Mallikarjun sir, can I just ask one question for the benefit of the population that allows?
Yeah. Yes,
Okay.
yes.
Alaric, I think so. One more thing we therapists need to really understand from you and Rujata is, yeah, we talked about prevention, we talked about surgeries, we talked about everything. But as we stand today, and as you said that Scandinavia and other countries don't have, you showed the graph so beautifully that hip surveillance has completely reduced, and we are just starting. So we are really encountering lots of kids who have dislocated hips, specifically the kids who are GMFCS 4 and 5. And I feel a lot of people don't understand that how important it is to send back to the orthopedic surgeon, get them operated, look at a holistic approach, look at their transitional care. And I think so that message would be so important that yes, there are kids who may require surgery, even it is as just simple. I mean, I feel that would be very, very important. One big loud message from you.
Yes, thanks, Asha, for those comments. I think that's absolutely perfect and right. In fact, when you begin a hip surveillance program in your own institution, because we began that in our institution just a couple of years ago, and what we realized immediately is the first thing that happens is that because of screening, the number of patients who are referred to us with hip problems really goes up. Whereas before we were seeing 2 or 3 children in a few months, now we're seeing more than 10 children sometimes in a month who come to us with a hip problem. The number of surgeries will increase exponentially, at least initially, in the initial part of your surveillance program, because all of these children who are not diagnosed before are diagnosed now. And you'll find a number of children who require major reconstructive surgery. But the hope is that as the surveillance program matures and children are being referred earlier and earlier, then the need for such extensive surgeries will decrease actually. So you'll see an initial spike in reconstructive surgeries. And then as the program matures, you'll find more and more children being referred earlier, where they can be treated very simply by soft tissue releases, by good abduction bracing, returning the child back to the therapist for doing physiotherapy, putting them back again in the surveillance program. And the number of these big surgeries will then reduce. What we definitely want to eliminate are the hip dislocations. We definitely want to eliminate children who come to us with the hip completely out, where the head is completely eroded, where there is no reconstructive procedure possible, and where we have no other go but to salvage the hip by excising the femoral head and neck. And that's not a nice procedure for us to do as orthopedic surgeons. We hate doing that because we are not reconstructing the hip. We're not creating a native hip. We are doing something which is extirpatory, which is something which removes a part of the body, and that's not something that we prefer to do. So I'm hoping that with hip surveillance, it's not going to be a sprint. We understand that this is a marathon. We understand this is going to take several years for us to understand the importance of hip surveillance, and bring these children in early so that simple surgery can eliminate hip dislocations in this group of children and help us to diagnose and screen them in time so that they can live productive lives.
Thank you, Alaric, for your words of wisdom. They are going to be really very helpful. As we come down to the end of our session, I just want to remind everybody that on the 18th of October, we have a very, very nice webinar, which is on early intervention by Professor Minja Hedders Algarer. She has a lot of work. We will start, I know it is a Tuesday, and we will start at 12:30. It will be for 1 hour. Hope you join and learn. And at the end, can I request our President Mallikarjun sir to convey the vote of thanks?
Good evening, and before going for a vote of thanks, and first I would like to thank our mentor, Dr. Ashok Johari. 4 years back, when we were discussing in an executive board meeting, he stressed the importance of developing guidelines, hip surveillance guidelines for cerebral palsy children, especially for Indian guidelines. Then we requested him to lead this project. So he has chosen all best professionals across the country and involved all the stakeholders, those working in the field of cerebral palsy and rehabilitation. 4 years, they had a lot of brainstorming sessions. They worked together, and finally they developed Indian guidelines for cerebral palsy and hip surveillance, and it was released in post-C midterm meeting at Bombay. I was also present in that meeting. I thank our mentor, Dr. Ashok Johari, for proposing and taking the lead and making these guidelines to come into existence, and they released the guidelines for the country. I thank Dr. Alaric Aroojis for giving a consent to give a lecture at our Indian Academy of Cerebral Palsy webinar, despite of his busy clinical schedules. And I thank Dr. Rujata Mehta within a short notice. She accepted our request to moderate this session. I thank you very much. And this is a third in series. On the occasion of National Cerebral Palsy Day, we celebrate every year the October month as a National Cerebral Palsy Day month. In memory of Perin K. Mullah Firoz, our founder president, who was the first lady orthopedic surgeon, who spent her whole life for the empowerment of children with a cerebral palsy. We pledge to continue her ideals and try to work hard for quality and effective service delivery for the empowerment of children with a cerebral palsy. This series we have we wanted to have a lecture where there is a consent from Dr. Kerr Graham to talk on JFCMCS, but due to his some other commitments, he was unable to talk during this month. Very soon we will be having his lecture on the topic, mostly in the month of November or December. We always, IACP tried its best to invite the reputed speakers to teach, train the young professionals to enrich their professional skills in order for the best service delivery for the children with the cerebral palsy. This time we would like participants to express their reflections on this webinar. I request the participants to speak on the webinar and the quality of it is a feedback, we can say that. I request any of participants can speak their views and feelings and their feedback on this webinar.
Yeah, myself Pradeep. Can you hear me, sir?
Yes, we can hear you, Pradeep. Go ahead.
Yeah. I wish to convey my sincere thanks to Dr. Alaric. Actually, Dr. Alaric mentioned that once our mind doesn't know, our eyes cannot see. So Dr. Alaric has given that side to us, that knowledge to us, that we can implement it at any level. I wish to convey my sincere thanks to Dr. Mallikarjuna, President Sir, for organizing such a nice academically rich program. That's all. And already we have more than 25 programs which is going on continuously. This type of knowledge exchange actually enrich us, all of us, for the benefit, those who are actually in need of benefit from us, that we can reach to the unreached, which is the mission of ISCP. Thanks to all.
Thank you, Pradeep, for your kind words.
Thank you.
Sir,
Sir, can I speak?
Yes, please.
I'm Dr. Jagdish from Apollo, Hyderabad.
Yes, please, Dr. Jagdish, speak.
Thank you. Thank you very much. I would like to extend my thankfulness and gratefulness to the today's faculty, Dr. Alaric, Aroojis. Thank you, sir. Thank you so much. You have been dealt the various inputs, I mean the concepts regarding the cerebral palsy, that is a hip displacement, cerebral palsy, and also its consequences. In India, out of 1,000, 3 children are identified with the cerebral palsy. This is what the prevalence and incidence really globally it is increasing because of the various ecological factors. Of course, hip surveillance, early intervention can definitely eliminate the hip dislocation or subluxation. And already you mentioned that Australian and British Columbia and American Academy of Cerebral Palsy, they have been developed many guidelines from time to time. In India, definitely there are some barriers, obstructions because of the so many cultural, geographical, and also the social, financial, so many, ecological factors. Of course, you are doing your best from Orthopedic Society as well as Indian Academy of Cerebral Palsy. The people are doing best in changing the guidelines from time to time on research based. And also there is an emergency urgent need. As you said, definitely these guidelines should be reachable to each and every corner of this country. So in India, medical officers, preferably who are practicing in government sector, like primary health centers, where the medical officers, definitely 1 or 2 will be there. So these medical officers in government state, the central, whatever the government, they have to be known. This dissemination of the knowledge, it has to be disseminated among the medical officers and also ASHA workers. Because there is a program already, that Rashtriya Bala Swastha Karyakram, RBSK, the government of India, the National Health Program NHM. So this ISCP, definitely, I think it is better to be as a partner in the National Health Mission Government of India under RBSK for the efficient implementation of this hip surveillance. Because this is not only at risk, I think I can say it's at high risk, as you said, as mentioned. ASHA workers, if you provide some basic functional guidance to conduct some kind of home surveillance to identify this, because the newborn baby will be generally followed by ASHA worker. The ASHA worker will be visiting the home of the, the mother, the maternal. So there she can, identify certain, the problems regarding the hip. Okay, so if ASHA worker educated or, empowered, definitely it will be reached to each and every woman, the mother. And also you explained very excellently that is rational and significance of this, information, that is pre-operative and post-operative guidelines you mentioned, and also non-operative methods, strategies, and also evidence-based scientific surgical methods. So surgical methods are really good. Of course, it gives the best results. But in India, most of the time, what is happening, the physiotherapists, the rehab professionals, generally, they will be dealing the children with, cerebral palsy, because in urban setting, orthopedic surgeons will be available. But when you go to the rural area or agency, tribal India, definitely there won't be, orthopedic surgeons. Tertiary care will not be available. So I sincerely, just recommendation or advice, whatever ISCP can do much better, in approaching the medical office of urban, the rural population, so that we can cater the needs of the children with cerebral palsy. And also, this is a very valuable day-to-day guidance, which are very scientific evidence-based information you have been, given, and the multidisciplinary team of professionals should be, involved in this process of hip surveillance or save hip joint in the children. That too, because the neurodevelopmental follow-up will be there anywhere in the preterm or very low birth or extreme low birth babies who are NICU, NSU. So these are the children, they are going to develop certain disabilities, developmental disabilities. So every child who got admitted or who is going to be discharged from NSU, this surveillance, periodical surveillance should be done by the neurologist, pediatric neurologist, and also pediatric orthopedist, and also pediatric physiotherapist or a pediatric occupational therapist, because these are the babies who are going to develop certain problems or disabilities. Because the difference between disabilities, diseases, difficulties, or disorder, it is generally a lot of differential variation is there. So this has to be disseminated among all. I really thank, I am extending my thankfulness and gratefulness to the President of the Indian Academy of Cerebral Palsy, Sri Mallikarjuna Garu, and also the Secretary, and also the Joint Secretary and the team, and also Rujata Mehta Madam for the moderating of the scientific deliberations on cerebral palsy. Once again, I conclude, I am so grateful and thankful for you, sir, Alaric, sir, for giving such a wonderful evidence-based practice guidance. Thank you so much. Good evening, everyone.
Thank you, Dr. Jagdish, for your kind.
Thank you, Dr. Alaric, and thank you, Dr. Rujata Mehta, and thank you, Jagdish, for your feedback. Thank you very much, and thank you for your kind support.